You are watching the DocTalk show.
So welcome back. We are discussing prostate cancer, and with me is a senior urologist from Novik Hospital, Dr. Mohan. He has vast experience in the treatments of prostate disease, in particular prostate cancer. So Dr. Mohan, the treatment of prostate cancer, first of all, is it treatable or is it curable? I think that's the first question people will ask. Of any cancer, is it treatable or curable?
Very good question. If diagnosed early and the prostate cancer is organ confined, then it is eminently treatable and curable.
And curable. Only if it is...
If it has gone beyond the prostate, then the question comes of control, enhancing quality of life, trying to preserve quantity of life as compared to a cure. So we control for non-organ confined or metastatic cancer prostate and cure for organ confined cancer prostate.
Okay, so basically the cancers which are picked early and are still within the prostate gland
Absolutely.
can be cured.
Yes.
Yes, and those that have gone beyond the prostate
We
gland,
just can control the negative effects of them.
okay, we can't cure it because it has
cannot
gone
cure
beyond
them.
the confines of the prostate.
Absolutely.
The prostate gland. So in the treatment, let's start with the cancer that is only within the prostate.
Okay.
How can one cure such a cancer?
There are two basic ways of curing the cancer. One is radical prostatectomy, which is a surgical procedure.
What does it mean?
It means you remove the entire prostate. Unlike age-related non-cancerous enlargement of the prostate, where you endoscopically remove only the core of the prostate using laser. Here you remove the entire prostate as a complete package. You remove the attached seminal vesicles, and you also remove the pelvic nodes on either side. Because if one cancer cell has escaped, say from Uganda, it would have gone to Rwanda. So you remove Rwanda also.
So you're removing the surrounding
lymph node
structures,
along with the prostate and the seminal vesicles. Okay. That constitutes radical prostatectomy. And this can be done by open surgery. This can be done by robotic surgery. This can be done by laparoscopic surgery. Okay. But whatever be the technique of removing the prostate, we are looking for three endpoints. Endpoint number one, there must be complete cure from the cancer. Endpoint number two, the patient should be able to pass urine with control by 6 weeks. So cure of the cancer at the end of the procedure, same day as the procedure. Confirmed by the pathologist the same week. Ability to pass urine with control by 6 weeks. And ability to resume relationship with the spouse by 6 months. Okay. So
the surgery seems to have a
6 weeks. Yeah, these are the three things. If you achieve all three, cure of the cancer, continence and potency, it's a well done procedure. Okay. So whatever the modality, open, laparoscopic or robotic, you should achieve these three landmarks.
So if you fail to achieve any of them, would you say it's a failed
I wouldn't say
surgery?
It's a failure. I would consider it a failure if you can't cure the cancer.
The goal is to cure the cancer.
Yes. If the other two are added on, then I would call it enhanced cure as compared to just a cure. Because besides restoring quality of life and quantity of life, the man should be able to enjoy the period that has been restored to him. Only if he is continent, and especially in the African context, he is potent, will he enjoy that which has been returned to him.
Enjoy his, the sexual function?
Sexual function and the ability to be mobile without wearing a diaper. So that's a very critical element. Of course, we have restored him, cured him of the cancer. But beyond the cure, there is a man who needs to live.
It's the collateral damage which
yes.
comes as
So
cancer.
all the three are essential for an enhanced cure of the cancer. The alternative is radiotherapy.
Radiotherapy. How does it work, radiotherapy?
Radiotherapy in the olden days used to be external beam, had profound side effects. Generally, Africans and Indians do not tolerate radiotherapy as well as Caucasians, as white people. So if you look at it, in the United States of America, 75% of all cancer prostates, organ confined, are treated with radical surgery. But if you look at Europe, 75% of all cancer prostates are treated with radiotherapy. Now, how does it work? Today we use what is called as intensity modulated radiation therapy. That is, it is not a carpet bombing of the cancer or of the prostate. Only those areas which have a high percentage of cancer cells, maximum amount of radiotherapeutic energy will go there.
So it's like a guided, first the prostate is mapped, the image is mapped,
yes,
like where the cancer cells are.
Correct.
Then the machine somehow
it guides the radiation beam to exactly go like a target in a shootout. The core is where you have to hit. So each time where the cancer is where radiation energy will go. It's focused to those areas where the cancer cells are hiding.
How would the doctor tell that the cancer is in these areas?
We do what is known as radiation mapping or cancer mapping, using a combination of MRI and modern day software algorithms. It would be possible to map biologically where the cancer is, and then you focus the radiation energy specific to those areas. That is why it is called intensity modulated radiation therapy, IMRT. Once the marking is done over 2 to 3 days, the treatment of radiation therapy continues for 6 weeks, 5 days at a time, Saturday, Sunday being holidays, and it is given in small fractions, so that small doses, so that so that the patient doesn't suffer much side effects. So those are the two modalities, either surgery or radiation therapy in case of organ confined cancer prostate.
And how well do they achieve the goal? How well do they cure?
Both of them provide on an average 90% cure when well done, and about 10% what we call as upgrading. Subsequent to the procedure, either surgery or radiation, we find that the margin is positive, or the biological marker PSA doesn't come below 1, or a subsequent scan will show that disease may still be there, in which case in the remaining 10% an additional modality will be required. If the initial modality was surgery, then radiation would be the additional modality. If the initial modality was radiation, salvage surgery would be an option. Or we'll have to add medications in either arm. So in other words, a single modality approach to cure the cancer will need an additional modality to ensure the cure is complete.
Okay. So that is mainly for the cancer confined to the prostate.
Yes.
How about if the cancer goes beyond the prostate? What they call
metastatic cancer prostate. Yes, if it does happen like that, then we do what is known as maximum androgen blockade. What does it mean? We know that the prostate cancer cells need testosterone as the food. So if you cut off testosterone, the cancer cells will die. So 90% of the hormone testosterone is secreted by the testes, 10% by the adrenal glands. So either you can do purely medical castration, that is, use a combination of centrally acting drugs to block testosterone releasing hormone, and locally acting drugs so that the testosterone doesn't reach the prostate cancer cell. This combination is called medical castration.
Okay, so in other words, you're blocking the production of testosterone.
You're blocking the production as well as the ability of the testosterone to reach the cancer cell.
To reach the cancer cells. That's why it's called medical castration.
Yeah.
So you're starving the cancer cells of
their essential food, so that they can't multiply.
Okay. And so when they are starved, they
eventually die.
Okay.
And the other way would be to remove the testis and just give a tablet. That's the cheap, safe, efficient way, especially in countries like Uganda and India, where the expensive medical castration may not be an affordable option. Simple orchidectomy with that simple tablet like bicalutamide once a day for 9 months may ensure excellent castration.
Why would we remove the testis?
Because they produce the testosterone.
Okay, it is a source of the testosterone.
It's a
So you're getting
90%
rid of the
source
of the
90%
testosterone.
source of the testosterone.
Okay, so and that will in a way control and
It will
reduce.
bring down the testosterone level to below 50 micrograms. Normal level is 250. Once we reach 50, we know we have got a cure or a control, adequate control on the disease.
So this is keeping in mind that we're dealing with metastatic disease. The treatments will not cure, but will control the extent of the disease.
Correct.
Please remember to send in your questions or comments to the social media platforms. After the break, we shall be understanding how to prevent cancers and if there might be some cancers that don't respond to the treatment. Yes, so please stay tuned, don't go away.
You are watching the DocTalk Show.